Let's discuss immune thrombocytopenic purpura ITP. It is an idiopathic condition where there are antibodies against glycoprotein 2b3a on the platelets, and it causes low count of platelets, and that increases the bleeding time, and there will be no changes in PT or PTT. The bleeding time here is high because the platelets are quite low. And for the USMLE questions, platelets in ITP are usually less than 100,000. And it can be precipitated by the viral infections. Now, when we get viral infections, there are antibodies against viral proteins that cross react with the platelets, and it disrupts the platelet aggregation. Since the antibody is reacting against the platelets, we also classify this as type 2 hypersensitivity reaction. Viral infection will be asymptomatic in 50% of cases if you are studying for USMLE. In other words, question need not mention the viral infection, so you just don't get confused with that. So for USMLE, it can be present in two scenarios. One could be a school age kid like around 12 to 15 years who has coryza for the few days and followed by petechiae or the nosebleed, and the lab finding will show that platelets might be in 80s or 90s, and that's how you know it is ITP, because it is precipitated by the viral infection. The other could be the woman in 30s or 40s, and there will be no mention of viral infection, and there will be random bruising and bleeding time of 9. And if you go for the lab finding, the platelets would be like in 40s, 50s, and that's how you know it is ITP, and the question will not mention any prior viral infections. And there is usually unusual questions where they can say that a girl only has heavy menses, and classically it is a clotting factor presentation for von Willebrand disease, but in many option choices the von Willebrand disease won't be present, and the answer would be ITP. Just have a note of it. And the treatment includes steroids, which we're going to try first. The first thing that you're going to give, the first line is steroid, and then IVIG, that is intravenous immunoglobulins, and then you're going to go for the splenectomy. So this is the sequence: the steroid first, then IVIG, then splenectomy. So if splenectomy is performed, let's suppose a question presents to you as splenectomy is done in a patient with ITP, and then platelets then comes up to the normal range, and then 6 months later they again come back to you, and here the platelets are again fall down, and your answer should be accessory spleen. It is weird, but small percentage of the people have second spleen, the size of a pea-sized, and that can grow in size if the main spleen is removed. So just keep this point also in mind. Thank you.